Esta la quiero acá. Sí, estos suelos son un desastre, hija. Sí, hace rato debiste haberlo sacado. Hello. So good morning, huh? So we are here with my friends from Japan, huh? From Pentax Medical. That's right. So we are proving a lot of new technologies that they are development. But today we have a really nice case that I would like to show you some small tips with new technology that we can apply in our patients. So this is a patient that was sent to us because history of Barret's esophagus and dysplasia. No importa, no importa. And I would like to just to show you a little bit how to use the technology. So this patient have reflux disease because of this history of Barrett's esophagus. But sometimes in some kind of patients, we don't have any kind of lesion. We don't have esophagitis, we don't have Barrett's esophagus, and these patients are considered as a non-erosive reflux disease. And more investigation is necessary for these patients, other kind of examinations, okay? So nowadays, we have digital chromendoscopy, but with high definition scopes, but we have also optical magnification. And this will be published in a few weeks in Endoscopy International Open, and a study performed in this institution regarding how to determine the intrapapillary loops in the esophagus, in esophagus that appears to be normal. So if we are looking with white light, with the white light of the scope, white light vision, we see nothing. This is a normal esophagus. So if I apply an optical magnification, so we have a MagniView scope now, and I am looking to my vessels and to my mucosa 160 times of increasing of my optical vision. But this is still nothing. We don't see nothing. And I am using a post-processor filter digital chromendoscopy that is eye scan. But using the new digital chromendoscopy that is called OE, optical enhancement, we can see these small lesions red small lesions you can see over the surface, over the big vessels, and this is dilation of the intrapapillary loops of the mucosa. So with this we can have an accuracy of at least 87% to detect non-erosive reflux disease. So you can see here we don't see nothing, so there is not inflammation in this area. But if we change, we start to see some vessels. With this optical magnification we can see also how the blood passes. You see? So in cases of patients that we cannot detect any lesion, And this technology can help us to have a better diagnosis in our patients, and this is how and why we use also in all our patients the optical magnifications to detect any kind of lesion. Okay, so now I will be focused more a little bit in the Barrett esophagus because this patient was sent to us because of this area of dysplasia. So this patient have an esophagitis. You can see here an area of inflammation here. Down at 6 hours, I will try to change my scope, vision, and you can see here very well. Use the water, huh? So we have these small red spots, irregular red spots, that this is just inflammation. I don't see any suspected area of dysplasia. I just see inflammation. And if this is a Barrett esophagus, this is a very small Barrett esophagus, huh? Very short. This is not a big Barrett esophagus. I believe that is more gastric mucosa. This is the cardiac region, and I don't see any lesion. So, and this is another lesion, but this is to my opinion, this is a gastric mucosa, ectopic gastric mucosa. You can see here. How we can see very well the vessels and also the pit pattern. I don't see any irregularity. So to my opinion, this is a gastric ectopic mucosa. So I will use confocal just to determine if this is if there is any change of dysplasia in this patient, because if we saw in some small Barrett esophagus dysplasia already, and when we have that, we can do and we need to do a treatment. Okay, so we will use the confocal. Puedes pasar la fluoresceína, por favor. So confocal laser endomicroscopy give us a vision of 1000 increase in the optical. So we need to use fluorescein also to see the cells. Pasó la fluoresceina. So we need to wait a few seconds. So this is a squamous epithelium. Now we are looking now. This is the cardiac region. This is the inflammatory area. You can see here, and we see probably this is a Barrett's esophagus. This is a small Barrett's esophagus here in this area. You can see very well. My situation is that I don't see the globed cells. But at least I don't see any change regarding dysplasia. If this is a Barrett's esophagus, there is no dysplasia. So, to my opinion, there was a mistake. How I can see a dysplasia? You can see how we can see the gastric metaplasia. This is a gastric metaplasia. So this is not the same image. This is the intestinal metaplasia. So I don't see the globed cells. Is that the dark points in the borders of the lesion, but it's a little bit similar to this. So to my opinion, this is a small Barrett's esophagus, okay, but without dysplasia, just intestinal metaplasia. To see dysplasia, we need to see some areas like these ones with some irregularities and with the nucleo very dark, and we don't see nothing similar. So to my opinion, this is a Barrett's esophagus, a small Barrett's esophagus without any change. So why is it's very important to see these very well these alterations and to determine if there is any dysplasia or not, because it will change the rule. It will change what we need to do with this patient in terms of treatment. A little bit difficult to have the image. I will clean a little bit. This is a squamous epithelium. I don't see any lesion now, any dysplasia. This is a scar of the biopsies. This is inflammatory area with the squamous epithelium here. This is very inflamed area. I will take a biopsy from this area. Just inflammation, But this squamous epithelium is very inflamed. I don't see any destruction of the architecture of the epithelium, so I think this is very inflammatory area. You can see very well the squamous epithelium. Maybe we need to take a biopsy from here. Because in terms of Barret's esophagus, it's a very short Barret's esophagus without any dysplasia, and probably could be here some change. Okay, I will see here. It's just here. I always use my optical magnification with confocal. It's very useful. At least to use to see the my targets. Okay, we will see this area now. A little bit difficult, huh? Inflammatory areas of the esophagus. Oh, here. This is very inflammatory. You can see the vessels, very big vessels, and this is gastric ectopic area. Huh? It's not. Maybe here. Huh? Okay, here there are some change that could be dysplasia, but this is over not over a Barret's esophagus, huh? This is more over gastric ectopic lesion. It's rare, but probably because of inflammation. You see a lot of vessels. This is a crypt completely alterated, and probably we need to resect these areas. Just retire this area. I think we need to adjust the treatment also to increase the treatment of PPIs of this patient, and just that. Huh? This is normal, but this is not normal. This area and this area. Okay, so now what I will do is to perform a resection of this area using a captivator. Okay, we will retire the confocal. And I will change my scope, okay? I will not use optical magnification scope, because first, this scope is more for diagnosis. And second is because the reparation of this scope is is high. So I will use the I-10 series of Pentax Medical. This I-10 series is much better for treatment because I can use a working channel of 3.2 millimeters, and that's why I will change my scope. So, I, for conclusion regarding the diagnosis of these patients, is this patient is this patient have a gastric ectopic area with probably some dysplasia change. So we need to remove this area and not the small Barret's esophagus that this patient have. So maybe some of you are doing some question regarding why you will do the resection just with optical magnification. The accuracy for dysplasia is high, so have a good sensitivity and positive predictive value, but the situation is not going on that. It's because this patient have already a histopathology confirming that this is a dysplasia. So if I confirm my confocal, I will do my treatment. So we'll use captivator now. Hammer. Okay, sí, sorry. So always it's important to see if you will use a standard gastroscope. We are doing with a standard gastroscope because this is a 9.8 millimeters scope with 3.2 channel. So this is the kit of the captivator. You can see here, we will put this first we need to pass. Thank you. This. You don't need to remove the plastic. I don't know if you are looking here. You don't need to remove this plastic. This plastic cover you need to remove after. So you pass through the channel. Okay, once. Perdón. Déjame trabajar. We are here. So now. We just put like that, and now it's ready. Once we have that, we proceed to remove this plastic, not before. And then we have this area and we have the blue area. So we need to adjust here the distance of this metallic area. You can see? Okay. Perfect. Now we passed this as a ligation kit. Just in the middle. Okay. Now we open. And we pass in the middle. And now it's okay, okay? Thank you. It's very important to see this part, this sign, because this part needs to be just adjusted in the working channel. So you see here, we need to put very well this just to the top. You see this mark, the small plastic marks. Now I am good. You can see I don't see any band, and I have very good vision of my area, of my scope vision. Okay, so now we will put the lights. So we will perform the small surgery of this area. I always use digital chromendoscopy, the whole time, because all the meta-analysis showed that the white light doesn't work. It worked at once. And this is the area that we need to resect. So I will change to OE. I will fix now. And I will start to perform my aspiration, trying to keep in the middle my lesion. You see here, is under control the whole time. And now I will apply a band. I just do it. Okay, we would need a picture for the report. And now you have this in the kit. With this you need to perform a perforation of this area. Okay, it's just to pass my snare. Okay. ¿Puedes abrir? Abre. So I need to change my position now. I will change my filter. Okay. You see there? Now we have the lesion there. And now I need to keep and to catch my lesions inside my snare. So I will change my position, the position of my scope, a small rotation. So now we are good. Ok, cierra un poquito, por favor. Cierra. Cierra. Ok, momento. Abre, despacio. Okay. So now I have my lesion. My lesion is okay. Cierra. The lesion is up. That's why I use digital como lo cierra. ¿Tienes todo? Ok. Listo. Now I will cut. So we cut. I will recover my lesion. The lesion is here. Perfect. So this is the small area. You see? It's very well treated. So now I will just go coming back just to see how is the other part. I think it's very well. There was a small bleeding, but we have a band ligation, and I believe that there will be no any complication in this patient. So it's very safe to use captivator. So you see here, no bleeding. The band is here. This part will be, will have a necrosis, and the patient will recover fast. No problem. We finish. Okay, terminamos la transmisión. Thank you so much for your attention.